I have the pleasure of introducing our speaker for this evening. Dr. Saar Danon is the Medical Director of Pediatric Cardiology and Congenital Cardiac Catheterization at Memorial Care Miller Children's and Women's Hospital in Long Beach. As an interventional pediatric cardiologist, he specializes in the use of catheters and devices to treat children and adults with congenital heart disease. He is also active in the diagnosis and treatment of infants and children with all forms of cardiac disease, as well as adults with congenital heart disease. Dr. Danon is board certified in both pediatric cardiology and adult congenital heart disease. He's excited to join us today and provide a talk on chest pain, palpitations, and syncope, preventing sudden cardiac death. Welcome, Dr. Danon. Thank you for joining us.
Okay, thank you so much for having me and allowing me to join your group here. Can you guys all see the slides and hear me okay?
Yes.
Okay, great. Thanks for that very nice introduction. This is obviously a very big topic. We'll try to address it as much as possible. The reason I like to lump chest pain, palpitations, and syncope together because there's a lot of crossover. A lot of the patients that you guys see will present with multiple of those symptoms, and there's a lot of overlap in the diagnosis. And why are we so concerned with this? I mean, obviously, the main thing that we want to do is prevent something really bad from happening, and obviously sudden death being the worst. So that's why I like to include all these together. This is an example of a home care. That's the main point is really that these really tragic events are not just tragic to the patient and the family, but the close friends, the whole community. And this was caught on film. Most of the ones that we see in teenage years are not, but they're just as traumatic and devastating. So that's really what we want to prevent. We want to figure out which of these patients have these bad diagnoses. And you guys have a very tough job. You see a lot of patients a day, you see a lot of these symptoms, and the question is which of these require workup. So during this talk, I'm gonna cover some of the etiologies of chest pain, palpitations, and syncope. I'm gonna do so by giving some patient examples, some of the initial workup, who should be referred to cardiology, who should you limit from doing activity, and then some of the treatment options. So sudden cardiac death obviously is an abrupt, unexpected death of cardiovascular cause. You lose consciousness and resulting death within 1 to 12 hours of onset of symptoms. It is unfortunately representative of 5 to 10% of all childhood deaths annually. We worry about this in young athletes, also in all kids though. And the two most common causes are hypertrophic cardiomyopathy and long QT syndrome. So I'm going to quickly run through a couple of these patients, and then I'm going to go back to them and discuss them in more detail. The first one is Joanne, who's a 14-year-old female with intermittent chest pain for 2 months. She has a pain both with rest and exertion, and it's worse with inspiration. The second patient, Colleen, is a 5-year-old female. She has intermittent chest pain for 1 month. Her symptoms are predominantly at rest and self-resolve, although her father noticed that her heart is beating out of her chest. She's otherwise asymptomatic with normal growth and development. The third patient is Michael. He's a 15-year-old male with chest pain that occurred during a soccer game the day prior to the appointment, with some associated palpitations and dizziness that also resolved with rest. Jonas, an 11-year-old male that collapsed during a basketball game and was noted to not have a pulse. There was an AED in place and a shock was delivered. Toby is a 17-year-old male with complaints of frequent chest pain with activity that also resolved with rest. Then the last one that I'm going to talk about is Xander, a 15-year-old male with 2-day history of intermittent chest pain that's worse with activity, has had increasing fatigue, and had a recent URI. Now, we'll go into each one of these patients, but you can see there's a wide variety of patients with various symptoms, with definitely some overlap between them, but they each have a very different diagnosis. So when you see these patients, the workup obviously will include a very thorough history, your physical exam, EKG, and then if they're referred, an echocardiogram, a monitoring study, and then cardiology consultation in some cases. As far as the initial evaluation, you guys are all familiar with the 14-element cardiovascular screening. This is common for all athletes that you screen. It's part of the AHA and ACC guidelines, but I break it up into 3 different parts. The 14-element cardiovascular screening, it's really broken up into personal history, family history, and exam findings. So as far as the personal history, the main things to look out for is chest pain and discomfort, particularly related to exertion. If they've had fainting or near fainting episodes, if they've had other exertional symptoms such as dyspnea, fatigue, palpitations, if they've had prior diagnosis of murmur, prior history of hypertension or elevated blood pressure, if any physician previously restricted them from sports, or ordered cardiac testing. So those are the main things from a historical standpoint that should raise a red flag. As far as the family history, any premature death before age 50, which is attributed to heart disease, or disability from heart disease in a close first-degree relative. And then any known family history of the following: the cardiomyopathy, both dilated and hypertrophic, long QT syndrome, but there's other channelopathies like Brugada and things like that that fall into that as well. Marfan syndrome or other major connective tissue disorders, significant arrhythmias, or other cardiac conditions. So those are the things that should be thought about in the family history. As far as the exam, when you're seeing these patients, obviously if you note a murmur, femoral pulses are really critical, making sure that the patient has good femoral pulses to exclude any aortic obstruction, any of the physical exam findings for Marfan syndrome, and any elevation in blood pressure. Those are all the things that, again, should raise red flags. When you order an EKG, the main things that we can see are any rhythm abnormalities. We can see any chamber hypertrophy or enlargement. We can measure the QT interval, look at for signs of any channelopathies, Wolff-Parkinson-White syndrome, signs of ischemia or other abnormalities. So the one thing that I would really caution people is to not rely solely on the machine read. I just found out that one of the pediatrician's offices has been doing EKGs, and they go by the machine read, and we went back and found several abnormalities that were missed. So if you order an EKG at a hospital, just make sure it's read by a pediatric cardiologist. If you do it in your office, if you're comfortable reading the EKG, great. If not, I would, if there's any concerns, have a cardiologist review them, because things are missed. There have been studies that have shown that the machine is accurate about 50% of the time. This is the most common thing that we see on EKG, sinus arrhythmia. It's a really bad name for a normal finding. It's not an arrhythmia, it's just respiratory variation leading to some irregularity in the rhythm. As you know, during inspiration, you increase your venous return, heart slows down, it takes a little longer to eject, and during expiration, the heart speeds up. This is a completely normal finding. If someone reads sinus arrhythmia on an EKG, that is normal. Typically, when I read these, I will say sinus arrhythmia and then also say within normal limits for age, because I don't want to confuse this with another arrhythmia. As far as PACs are also something that we see very commonly. Most of you guys that work in and see newborn definitely will see PACs. Many times in newborns, you'll hear some irregular rhythm. And most of the time it's PACs, it can be PVCs, but that is essentially a normal finding in newborns. We don't worry about it as long as electrolytes are normal and their exam is otherwise normal. Most of the time, by the time they see you, the pediatricians in the office, the irregular rhythm has normalized, but if not, at that point, you can refer for further evaluation. One thing that's important to note is all the bad diagnoses that we talk about, whether it's long QT syndrome, Wolff Parkinson White, Brugada, ARVD, the culminating factor in all of these and the true cause of sudden death is torsade. So it's a form of ventricular tachycardia, which is a non-perfusing rhythm. The baseline EKG and the abnormality that you see, in essence, doesn't cause any symptoms, but they're at risk for developing torsades. And that's what we're trying to avoid in all of these is a non-perfusing rhythm. An echocardiogram, this is an example of an echocardiogram. It's what we call a four-chamber view. I'll just point out a couple of things here. You can see the left atrium and the left ventricle, the right atrium and the right ventricle. You see the mitral valve here flapping and the tricuspid valve. So what we can see is we can see any structural abnormality, if there's any valve abnormalities, septal defects. If the muscle itself looks thick or hypertrophied, we can see the heart function here, how well it's squeezing. If there's any fluid around the heart, which we don't see in this case, these are all things that we can see on echocardiogram. As far as a monitoring study, it's gotten pretty confusing. Obviously, we all are familiar with EKGs. As far as Holters and other monitors, it used to be that we had 24-hour Holters and then we had 30-day event recorders and we didn't have anything in between. Now there's a wide range of different cardiac monitoring studies. The two brands that you may have heard is ePatch and Zeopatch. The nice thing is it's really just a patch. It's a patch, it has a chip on it, and they can shower with it, they can play sports, they can do everything with it. We can leave it on from anywhere to 24 to 14 days, and these have really helped diagnose a lot of cardiac abnormalities. We do have the ability to do an ambulatory cardiac telemetry, which is real-time home telemetry, which essentially is the same thing, but they also carry around with them a phone so that if they have a dangerous rhythm, it immediately alerts the company we use, it's LifeWatch, and then they call us. So within, I would say, minutes, a physician is able to look at the rhythm. So in the patients that we're really concerned about, we'll order it as a home telemetry. But from the patient's perspective, it looks very similar. They're still able to shower with it, do everything with it. And if we're unable to diagnose something and we really are worried, we can go to an implantable loop recorder, which is a surgically implanted recorder. It's about the size of a stick of gum, and it can stay in for a long period of time, for over a year. Thankfully, we hardly ever need to do that, but that is always a possibility. The one thing I would add is one of the most important data that we get from these is what's the heart rate during the symptoms. And every one of your patients has something that we can use to detect that, and that's their phone. And I'll go over that a little bit more later, but one of the things I always do is have them download a heart rate monitor for their phone. That really helps us a lot, because if you have a patient that's complaining of palpitations, and their heart rate is 110, you're not going to be nearly as worried as if it's 170. So that's something that's really easy to do. There's a ton of free apps. You just say heart rate in the App Store or the Google Play Store, and it just uses the camera and measures the pulsations on the fingers. So I definitely encourage everyone to just download one of these, play with it, try it yourself, and then recommend it to your patients, because that's really going to help you differentiate some of the pathology from the normal sinus tachycardias. So some of the diagnoses that we may see, the benign diagnoses, we all see non-cardiac chest pain, mainly caused by costochondritis, and in some cases reflux and other causes, benign palpitations, which usually represent sinus tachycardia, benign dysrhythmias, vasovagal syncope or neurocardiogenic syncope. And then we obviously are trying to find some of the pathologic rhythm abnormalities, including channelopathies, looking at cardiomyopathy, myocarditis, and structural heart disease. Yeah, and someone in the chat said Apple Watches are helpful. That's very true. A lot of patients do have Apple Watches or Fitbits, and again, I encourage them very much to look and tell us what the heart rate is at the time of symptoms. So we're going to go back to some of our cases. The first patient was a 14-year-old girl with intermittent chest pain for 2 months. It's both at rest and with exertion, and it's worse on inspiration. So on your exam, the exam is completely normal, and I don't recommend any additional workup at this point. If they have a pain that's both at rest and or predominantly at rest, and your exam is normal, and in most cases, that's going to be a benign finding. Obviously, you want to think about the other points in the family history and all those, but in most cases, those are going to be very benign. And most of these are going to be costochondritis, and can be treated with NSAIDs. One thing that's very important, if we're treating these with ibuprofen, what I always tell the families is you can't wait to have the chest pain to treat it. They need to be on TID dosing of ibuprofen for at least 5 days, whether or not they are having the pain. I tell them to take it with food. And then after the 5 days, see if that's improved things. And the main reason for that is because we want to get rid of the inflammation. We're not using the NSAID as a pain med, but as an anti-inflammatory, and they really need several days of anti-inflammation to see a difference. The other things that come up often is reflux causing chest pain. I just had a patient this week that I see annually for bicuspid aortic valve, and a year ago I saw her, and turns out that she was eating a lot of hot Cheetos, and when she stopped that, they got better. I saw her back again a year later this week, and she said, I'm having chest pain again, but I remember last time you told me to stop eating the hot Cheetos, and I started eating them again. So she realized herself that that was the cause of that. All right, so we're gonna move forward to the next case. If anyone has any questions, please feel free to put them in the chat. Otherwise, we can save them to the end, but feel free to interrupt me. The second patient is Colleen. She's a 5-year-old girl with intermittent chest pain for a month, and mostly with rest, that's self-resolved. But her father has noticed that her heart is beating outside of her chest. She's otherwise asymptomatic with normal growth and development. It looks like there's That's a good point. Someone else pointed out the reproducibility of the chest pain. Yes, with costochondritis, that's one of the things you definitely look for, is whether or not you can palpate and reproduce the chest pain, or a lot of times with motion of the arm and stretching will elicit the pain. So anytime you can elicit the pain, either palpation or something they're doing, take a deep breath, that's a really good point I forgot to mention. Sorry, back to this patient. So this patient is complaining of chest pain, but her father notices that her heart is beating out of her chest, and you see them in the office, and it's a completely normal evaluation. One thing that's important to note is kids really have a tough time interpreting chest pain. So oftentimes, like a 3-4-year-old, sometimes even 5-year-olds, may interpret tachycardia and palpitations as pain. Sometimes they'll tell you very different things. They'll say, "Oh, my heart is beeping." They may say, my chest hurts. But a lot of times when you ask for the question, it's really palpitations. So anytime a young child talks about chest pain, I definitely would think about palpitations. And this is where family education is really important, trying to assess what the heart rate is. And again, if they have an Apple Watch or Fitbit, or if you download one of these apps, I think it's really really helpful. Even for babies, I've found that you can get the apps to work if you use their big toe. And in some cases we're able to do that. It's much easier than teaching them how to count the heart rate, either with a disposable stethoscope or with something else. Now a lot of people also have purchased pulse ox monitors since COVID, so some of those can help with knowing what their heart rate is. But making sure they keep a diary of their symptoms, what's their heart rate, and any associated symptoms. So this particular patient had a home cardiac monitor after referral to cardiology, and was diagnosed with narrow complex tachycardia, and this is actually SVT, or supraventricular tachycardia. And this is the most common abnormal rhythm in pediatric patients. Some of the hallmark features of SVT is they feel their heart racing, and it starts rapidly and stops rapidly or suddenly. Most kids that are having palpitations, their symptoms almost always start suddenly. But one of the hallmarks is they tell you, "Oh yeah, my heart is beating fast," and then it just stops. So I very specifically asked that, because the onset is almost always rapid, even if it's anxiety or sinus attack for another reason. But the resolution should be pretty abrupt if it is SVT. If the tachycardia goes on for long periods of time, meaning several hours, eventually it affects their cardiac output. They can become more lethargic, have poor color, and CHF. What I tell families, if their symptoms are going on more than 30 minutes or an hour, that they should go ahead and seek medical attention and try to go to an urgent care ER. Now, if you're able to know their heart rate, that's going to be really helpful. Most times SVT, the heart rate's greater than 200, but we will see it sometimes at around 170, 180. And there's other causes of tachycardia as well that maybe may not be as fast, but usually it will be well above 150. And again, most of these are narrow complex, but occasionally we will see a wide complex tachycardia that is an SVT. And the way we know the difference is it's a perfusing rhythm, and they're usually not having a lot of symptoms. Reentrant SVT is a hallmark of WPW, or Wolff Parkinson White, and what you see here is a wide QRS. This is at baseline, not while they're having symptoms, and this is because an extra accessory pathway. And Wolff Parkinson White is one of the things that we're screening for, which can lead to a sudden cardiac event. But what happens is they're completely asymptomatic, but then they become symptomatic when they go into SVT. So this predisposes them to SVT, because there's an accessory pathway connecting the atria to the ventricle. The acute treatment in kids is almost always adenosine. And in some cases with WPW, we will want to restrict them. So we'll usually do a treadmill for them to see what their risk with exercise is. Long-term treatment will depend on how often they're having symptoms, whether it's observation, medical therapy, usually beta blocker, sometimes digoxin. And then ultimately, we refer these kids for ablation. So if they're over about 15 kilos or 5 years of age, most families opt to go with ablation because it's a one-time fix. It's a very low risk, and then they never have to worry about it again. We're going to shift gears now to our third case, our 15-year-old male with chest pain during a soccer game that occurred the day before they saw you in the office. Patient had associated palpitations and dizziness that resolved with rest. That's a big red flag. If they had symptoms while they were active, resolved with rest, that's a big red flag. Physical exam, completely normal. You do an EKG, completely normal. And then you order an echocardiogram or a referral to cardiologist that gets an echocardiogram. And what we found in this particular case is an aberrant right coronary artery originating from the left coronary sinus. What does that mean? I'll show you. We exercise restricted them because this is a significant risk, and this patient considered cardiac surgery, and the patient actually went on to have cardiac surgery. We always will confirm the diagnosis of the CT before cardiac surgery, but this is a picture of what we see. So the picture on the right here, this is a normal aortic valve in cross section. So you see the aortic valve here. This is anterior, posterior, this is right, and this is left. This is the left atrium, the right atrium, right ventricle, and then the pulmonary artery is right here. The right coronary artery arises anteriorly from the right coronary sinus and goes rightward and anterior. And then the left coronary artery originates from the left side and bifurcates to the left anterior descending artery and circumflex. But this is a normal position of the coronary arteries. In this particular case, the right coronary artery, instead of originating right here, originates all the way back here by the left coronary artery. So in order to make its course over here, you can see it has to course right between the aorta and the pulmonary artery. So that this area of the coronary artery can get compressed. So when the child is exercising, their cardiac output goes up. There's increased flow in both the aorta and the pulmonary artery, which leads to compression here. If you have compression in the coronary artery, you can lead to ischemia to part of the ventricle, and then unfortunately that can lead to pathologic arrhythmia and sudden cardiac death, particularly VFib. We can also see this with the opposite, where the left coronary artery, instead of originating here, will originate on the right and then course this way. This is a lot less common, but a lot more likely to lead to a sudden cardiac event. So this patient had what we call an unroofing surgery, where the surgeon actually unroofed this whole part of the coronary artery, making one big ostia so that there's no longer obstruction to flow. And this patient did quite well. Unfortunately, these patients have completely normal exams. So the only way to diagnose these is with an echocardiogram. This next patient, Jonas, is a patient, the 11-year-old that collapsed during a basketball game. Thankfully for this patient, this was at a school in Orange County that had an AED. So there was someone that immediately noticed there was no pulse, put the AED on the patient, and a shock was delivered. The patient was successfully resuscitated. The echocardiogram demonstrated hypertrophic cardiomyopathy. The patient was exercise restricted. In these cases, depending on the specific diagnosis, can have medical therapy. Do they need an implanted defibrillator? Do they have surgery? And in some cases, heart transplantation. This is an echo similar to what I showed you before, but now this is that left ventricle. You can see the thickness here of the left ventricular wall. So this is severely hypertrophied. This is a picture that was in the OC register for this patient after he was successfully resuscitated, and he actually had surgery to resect some of that extra muscle to allow easier outflow from the LV. And did quite well, as you can see from the picture in the paper here, that this is one of the big reasons that we push for schools and athletic facilities to have AEDs, because it really does save lives. We've had a few aborted sudden deaths with these AEDs, so it's really critical, and it's also critical to have someone there that knows how to use it. Thankfully, most cases of syncope are not due to hypertrophic cardiomyopathy, and you see a lot of syncope, I'm sure, in your offices due to postural changes. Many times they'll have a concurrent illness. They might have a ongoing URI. They may have some dehydration. The big red flags are if there's exertional syncope, if there's associated chest pain, if they have palpitations and then they faint. Auditory triggers like loud sounds, that can be associated with long QT syndrome. If they have seizure-like activity, or if they have a positive family history of cardiac disease. Those are all red flags that should really make you think that this patient should have a further workup. For the majority of them where you suspect vasovagal syncope, the main thing is avoid the triggers. I think it very much depends on what's causing their syncope, but in some cases, certain positions. One thing that I always tell patients, if you feel like you're about to faint, you need to squat or sit, because, and I demonstrated it in the office, because by squatting, you increase your you increase your return to the right heart and increase your cardiac output, and a lot of times can abort fainting. But more importantly, if you squat and you faint, you're much less likely to get injured than if you faint from standing position. Increasing hydration is critical. I tell them at least 64 ounces of water, but in some cases they actually need 100 ounces. So I gauge how much they're taking and how much they need. Increasing their salt intake, avoiding caffeine, getting adequate sleep, at least 9 hours, really makes a difference for patients that have recurrent syncope. Daily exercise, this is something that's been shown over and over again to make a huge difference, particularly in patients with POTS, but in many patients with syncope, and then not skipping meals. And in some cases, we do need medications, although that's pretty rare. People are asking, what about psychogenic epileptic seizures? Also, anxiety can increase catecholamines and cause presyncope. That's definitely true. We also see catecholamine-induced arrhythmogenic right ventricular dysplasia. We see a lot of things can be catecholamine-induced, and those are definitely things that we think about. As far as how to prove orthostatic changes, which someone asked. What I do is I will have them lay down for 5 minutes in the office, and then we'll get heart rate and blood pressure laying down. And then I don't do a sitting, and then I have them do a standing heart rate and blood pressure after 1 minute, and again after 3 minutes. And if we see a significant increase in the heart rate, usually about 20 or more, significant decrease in blood pressure, those are all signs of orthostatic symptoms. We also, in many cases, it can be just poor hydration. And one of the things that we see is a decrease in the diastolic pressure. But those are all things that
Dr. Danon, before you move on to the next slide, there's a dark square in the middle of the screen. Is that supposed to be an image that we're supposed to see? Because we don't see it. There's a dark square.
Right here. Oh, no, I don't. Center. Right here?
Right in the middle, yeah, right there, yeah.
That's just an arrow. I don't know why you can't see it. It's just an arrow. Onset of symptoms.
Oh, I see. No, we see like a 3-inch by 3-inch square covering the wards. But we did see the wards before. I don't know what you did, but it has happened with other slides. I don't know what triggers that. But anyway,
it is still there.
It's still there now, yeah.
I apologize, sorry.
It's okay. When you
Is
move
it
to the
on the
next
next
slide, it
slide
should
as
go
well?
away. It's there now, yeah.
It's still there?
Yeah.
Hold on, let me see if I can stop the
I
presentation.
think it had to do with when you were reading the question that somebody posed.
Oh, okay, let me close that. How about now?
Still there. Now it's gone.
Oh, it's got, oh, you know what? It was, I was looking at the chat. Sorry about that. Okay.
Okay, thanks.
Okay, thank you. Okay, next patient. So 17-year-old male with complaints of frequent chest pain, particularly with activity, resolves with rest. Again, big red flag, it's happening with activity, resolves with rest. On physical exam, you note that a patient is hypertensive, has normal heart sounds, and absent femoral pulses. Again, it's really critical that you feel the femoral pulses. Echocardiogram is performed that demonstrates coarctation of the aorta. And I'm going to show you some of the cath images. This patient ended up coming to the cath lab. This is an angiogram. This is what we call a pigtail catheter. Is coming in from the femoral artery and is across the aorta. This is the aortic arch, the ascending aorta transverse arch with the head and neck vessels, and then this is the descending aorta. Right here, you see a very tight napkin ring, and you don't see great flow down to the descending aorta. You see these very big tortuous collateral vessels that are filling supplying blood to the lower body. But here you see a very tight narrowing in the descending aorta from the coarctation. This is actually a wire going up across the coarctation, and this is a balloon with a stent. And you can see when we inject contrast here that there is no flow here. So the entire width of this narrowing is only a couple millimeters. When we inflate the balloon, it expands the stent, and we can enlarge that stent. And then our final result here, you can see the aorta now looks completely normal with good flow from the ascending to the descending aorta here. A couple of points about this. This is much better dealt with early on in life. If this isn't diagnosed by about 3 to 4 years of age, the chance of this patient having lifelong hypertension is very high. This is a patient that had been treated for hypertension by a nephrologist for years, had seen another cardiologist, and interestingly, no one had documented absent femoral pulses. So this is one of the things that always stands in my mind as far as one of the reasons why we should always feel for femoral pulses in these patients.
There's a question in the chat. Is there any trick on how to feel femoral pulses?
As far as how to feel the femoral pulses, I don't think there's a particular trick. I think the more you do it, the better. In the smaller babies where it's harder to feel, I always use my thumb. Your thumb is much more sensitive. I like to hold the baby's hips, almost like you're checking for hip dysplasia, and I will put my thumbs over both femorals and try to feel the pulse. You will not confuse a baby's pulse with your own, obviously, but I find that to be really important. I think it's really just if you do it every single time, I think that's the best trick, because then it just becomes habit and you just get better at it. It looks like there's another question in the chat. I have felt asymmetric radial pulses before with coarctation. Yeah, so typically what I will do is if I'll feel for the femoral pulses and then the brachial pulses as well. And we feel for something called a brachiofemoral delay, particularly the right arm, and then one of the femorals. But if you feel sometimes a coarctation will involve the left subclavian artery, and that's why you may feel differential pulses in the left arm. But usually if you stick to the right arm and the leg, you're good most of the time. Okay, and then moving on to our last patient, 15-year-old with 2-day history of intermittent chest pain that's worse with activity, increasing fatigue, And this patient did have mild cough and congestion 1 week prior. Let me see what the question is here. Was Toby overweight or obese in any way? Just curious because his hypertension was treated only with medication instead of investigating the possibility. Okay. No, this was actually a relatively thin 17-year-old male. He was not overweight at all. The new recommendations for hypertensions are not to do extensive testing after 6 years of age, surprisingly. But I still think that there's obviously room for judgment there. But this particular patient did not have other comorbidities for hypertension. And then another chat here. Oh, thank you. You're welcome. So this patient, intermittent chest pain, worse with activity, again, big red flag, increasing fatigue, which is a little tough because a lot of teenagers tell you they're more tired, but this patient did have a recent URI. So this patient presented to the emergency department. In the emergency department, it was noted to be a little tachycardic, heart rate of about 110. Vitals are otherwise unremarkable. Normal cardiac exam, chest pain not affected by position or palpation. So not atypical. A lot of kids are tachycardic when they come to the ER. His labs demonstrate a normal CBC and electrolytes, but elevated troponin. So this is something the ERs have really started checking troponin a lot more. In teenagers, I would say over the last 5 years, and we're finding a lot more myocarditis. But if you have elevated troponin, that is essentially, in most cases, going to be myocarditis in this age group. The EKG was performed, and one thing that I will point out is all the T waves are very abnormal. So you can see the STs are very elevated, particularly in the lateral leads. You kind of see it diffusely in all the leads. So this is a very abnormal EKG. This patient had an echo, and I'll show you both of these. On the right-hand side is a normal echo. You can see this is what we call a parasternal view, but this is the left ventricle here. And you can see the left ventricle is squeezing right here. Okay, you have the mitral valve and the left ventricle. If you look at this patient's echo, you can see the left ventricle is kind of just rocking. It's not doing a whole lot. So this patient has myocarditis. So people are asking the difference between troponin I and troponin T. It's very dependent on the ERs, and most ERs are gone away from these, and we're seeing something called HS troponin or high sensitivity troponins. We typically have used troponin I in kids, and the high sensitivity troponin is a different assay for troponin I. The numbers are completely different. The assays are different from hospital to hospital. So what I would say is you really have to go by the normal range for that lab at that particular hospital, because even for the same test from different hospitals, you're going to get some variability. So if the troponin's elevated, it warrants further workup regardless of which it is. But again, the very abnormal echocardiogram there. So this patient was admitted to our cardiac intensive care unit, our cardiothoracic ICU, continuous cardiopulmonary monitoring, did have intermittent short runs of VTAC, but otherwise remained hemodynamically stable. Was treated with milrinone for about 3 days. The MRI did confirm the diagnosis of the myocarditis. We can see what we call late gadolinium enhancement aside of myocardial inflammation. This patient's cardiac function did improve over 10 days and was ultimately discharged home and doing quite well. These patients have to be restricted from sports because it takes their hearts a long time to recover, and they are definitely at risk for a sudden event. This is one of those things that causes cardiac arrest, and particularly with activity. Prior to being cleared for sports, this patient absolutely needs an exercise treadmill study. So while we're talking about myocarditis. This is obviously not a talk about COVID. I heard everyone's obviously talking about COVID early on in this meeting, but I just want to point out a couple of things. This is something that most of you have probably seen. These are the guidelines put out by the AAP as far as how can you, when should you clear patients to resume physical activity. It's going to be very dependent on their symptoms. If they have severe symptoms, MIS-C, they should have already been plugged in with cardiology. They're not going to be cleared for 3 to 6 months. The remaining of the patients, the majority of which are not hospitalized, it's going to depend on how many days they've had significant symptoms, including fever, chills, severe myalgia, things like that, 4 days for the more severe symptoms and 1 week for the other symptoms. Again, a lot of these patients absolutely require an evaluation in your office. Again, this same 14 element screening that we talked about, and they do require an EKG, and if they have symptoms or an abnormal EKG, they absolutely need to see the cardiologist. The tougher ones are this group. So you have a patient that tested positive, had the sniffles for a day or two, and now wants to go back to doing sports. Based on this, all these patients should have an EKG. What I typically tell pediatricians is, if they are competitive athletes, I used to say just high school or above, but even at the junior high level, some of the athletes are really competitive. They're really being pushed. But if they're really doing competitive sports and they've had COVID, I absolutely they should have an EKG before being cleared, and then they should be gradually allowed to return after about a week if everything's normal and they're asymptomatic. I just saw a patient this week that fell into that category, went back to playing soccer and started having symptoms with soccer, so is now being restricted, and we're doing further workup. But this is a big thing, that these patients should have an EKG before you let them go back to competitive sports. It looks like there is a couple of comments here. Let me see. Is a role for an enlarged heart on chest X-ray? Yes, definitely. Chest X-ray is very helpful, particularly if there's cardiomegaly. It's not as sensitive. By the time you see cardiomegaly and X-ray, you almost always, if not always, will see something on the EKG. What is the etiology of myocarditis? Viral. In most cases, it's post-viral. And as you know, we see it a lot with COVID. But any virus, all the older generation coronaviruses, influenza virus, Coxsackie viruses, a lot of the enteroviruses, those can all lead to myocarditis. Thankfully, it's not very common. We used to see this, I would say a few times a year, and now we're seeing a lot more of it. And do you recommend any dietary restrictions for kids with chest pain, arrhythmias, avoid caffeine, energy drinks? Absolutely, yes. That's one of my big things, and I had in that other slide, but definitely avoiding caffeine. I essentially recommend that in almost all the patients as part of what I discuss with them. And energy drinks, absolutely. Again, we see a lot of arrhythmias related to energy drinks. So that's the first thing. Avoid caffeine, avoid energy drinks. Healthy diet, those are things that we talk about with all our patients. As far as which of these patients refer to cardiology, sorry, there's another comment. COVID restrictions for young children, preschoolers. So when if they're really young, I usually will not restrict them. Again, it's really hard to restrict a 6-year-old, 5-year-old, and they usually stop activity when they get tired. If they've had very significant symptoms, then they absolutely should have an EKG. I would say if they fall into the moderate category or above, and then if they have MIS-C or were hospitalized, they definitely should have that evaluation. But if they had very mild symptoms and otherwise fine, I typically will not give them specific restrictions. As far as who to refer to cardiology, If they're exercise-related symptoms, that's a big red flag. Their activity should be limited and they should be referred to cardiology. If they have syncope that's clearly not vasovagal, or they have recurrent episodes of syncope, those patients should be seen by a cardiologist. If they have palpitations that are sudden onset and resolution, like we discussed, if they have frequent symptoms, particularly if they're not related to anxiety or stress, if they have other associated symptoms, and I typically say greater than 140, then those should be evaluated. Now, the reason I say that, and I emphasize that not everyone with heart rate greater than 140 during symptoms is having an arrhythmia, but most of the time when we see patients with sinus tach or anxiety, their heart rates are 110, 120. And if they're consistently above 140, then those should be evaluated. And that's helped, as someone pointed out, with the Apple Watch, or again, I tell them to download a heart rate monitor for the phone that uses a camera to measure the heart rate. If there's any abnormality on physical exam or the initial workup, those patients should be seen. And now they're asking me, are you seeing more cases of myocarditis with COVID infection compared to vaccine related? Absolutely. We see a lot more myocarditis related to MIS-C than we do with the vaccine. And that's one of the things that I tell families that are so worried about the vaccine, particularly kids with underlying heart disease. It surprises me when families are, oh no, they had heart disease, so we don't want them to get the vaccine. And I explain to them that it's just the opposite. They should get the vaccine because they have underlying heart disease. And we see so much more myocarditis related to COVID as opposed to related to the vaccine. So I make that a very big point when I talk to families. And someone asked, patient with a family history of hypertrophic cardiomyopathy, at what age do we screen? That's a really good question. If there is a first degree relative with hypertrophic cardiomyopathy, those should be screened. There's not a particular age. I'd say screen them when they know of the diagnosis. And then if they have a normal workup, in the past, we always said they should have a follow-up evaluation every 3 to 5 years. Now with genetic testing, I encourage them highly that if the affected family members has genetic screening and an abnormal gene is identified, that's really helpful, because then all the other family members can be screened and with a genetic test. And then if they don't have the gene, you don't have to do an echo every 3 to 5 years. So I highly encourage them to try to get the genetic testing. But as far as when to do it, I would say right when the diagnosis is made. How would you evaluate the obese child or unfit child who started to have some problems with exercise and effort to get into shape? How do you differ between poor conditioning and true organic disease in this patient population without the use of tests, or should we do tests in this population? That's a really good point. We see a lot of that. We've been seeing a lot of that, particularly around COVID, and with so many people being inactive. It is sometimes tough to differentiate, but if it's really just, you know, that they seem very unfit and can't and haven't exercised, then many times I'll try to reassure them. But if there's any abnormalities on the 14-point screen or something else that's a red flag, then I may at least get an EKG. You have to remember, I'm very biased because I see them after they're already referred to a cardiologist, so I'm much more likely to get an EKG and an echocardiogram. But as a primary care physician, it's a much tougher decision. So I would just go by your gut. But many of the patients may not require workup, but if they're continuing to have symptoms, I would at least get an EKG. So asymptomatic COVID needs an EKG, but real sick Coxsackie or influenza does not. That's a really good point. Again, I would go by their symptoms. If they had bad Coxsackie or influenza and have any potential chest pain palpitations, absolutely they should. But we see a lot less myocarditis and related to those viruses than we do with COVID and as a result of MIS-C. Should syncope workup include blood work? I typically do not include blood work as first line for syncope, except in some cases, like if it's a teenage girl with heavy menses and you're worried about anemia, things like that, may at least look for that. But I typically don't do that as part of my initial screen. Just to go to end this talk, this is a Belgian soccer player that you'll see that had a similar event. You see him collapse. There's a big difference. Watch his legs right over there. You see his legs up over there, and that's from the shock. So this is actually a patient that was diagnosed with a underlying heart condition. They said a rhythm, and I think you guys know, had an implanted defibrillator and then was allowed to return to play and actually put him in. So by making the diagnosis at the right time, was able to have a device implanted to and that's really what we want to do, obviously, is avoid anything bad. I'm not suggesting that these patients should return to play. That's obviously a personal decision, but at this point, I'll end the talk and answer any questions. This is the location of our clinics here at Miller Children's, where we have locations in Long Beach and Torrance and in Irvine. I put my personal email here. Feel free to take that down if you have a patient that you would like to discuss. If you just want to run something by me, if you have any questions about our program, you feel free to reach out to me directly. Looks like there's a few more comments. You guys are very welcome. I'm happy to answer any other questions if anyone has any questions. I will send out the slide deck. Tomas will have access to the slide deck and we'll send out a PDF version of that. Thank you for your time. I apologize for going over, but thank you for the opportunity to speak to you all.
Thank you, Dr. Danon. As a matter of fact, you did not go over. It's exactly 7:30 right now, so
great.
It was perfect timing. right on the second. Thank you so much for a wonderful presentation. I really appreciate it, and I know that the group loved it. There was a lot of engagement. So I will be sending the slides in a PDF format to everyone so that you can view them. And if you have any questions, I will also include the information on that last slide so that you can contact Dr. Danon directly.
Sure, great. Thank you, guys. It's nice to see you all.
Thank you for joining us and have a wonderful evening.
All right. Thank you all.
Excellent.
You're welcome.
Thank you.